pretty good crew logged in. I think we probably have a quorum. So why don't we go ahead and get started? I'm sure we'll still have some other folks join us along the way. As we usually do, we'll start off with our research in progress segment, and we are very pleased to have colleagues from the Connecticut Public Health PBRN sponsoring this segment of our meeting, and so I'll introduce our two speakers, Moira Lawson and Michael Knapp, with the Connecticut Public Health PBRN and the Connecticut Association of Health Directors. Connecticut has had a series of very interesting studies underway through their network over time. Connecticut PBRN was one of our networks that joined us in the second cohort of our PBRN program. So they have been up and running for at least 4 years now, I believe, and are doing have a series of interesting studies underway. We've heard from some of their research in prior editions of this meeting, and are now going to hear about some emerging findings from a relatively new project that was supported under our, I believe this was under our RACE initiative, our Research Acceleration and Capacity Enhancement supplemental grant awards that were made a year and a half ago to some of our networks, particularly with the focus on stimulating some health equity and health disparity related research within the PBRNs. And so I think this is a great example of some of that work coming out of the Connecticut PBRN. So with that, let me turn it over to Drs. Lawson and Knapp.
Thanks so much, Glenn. Let me see if I can figure out how to move these things. Okay. Before I get into the project, I want to offer you a bit of context. So I think that I really have to start with what is public health in Connecticut and what is the Health Equity Index, so that you can understand what we tried to do here. Connecticut does not have a governmental county structure. And what this means is that we don't have any county health departments. What we have is a group of disparate entities that deliver public health in the state. This is because Connecticut is a home rule state, so every town and city can decide by itself what kind of public health it wants to offer. What we've ended up with are, and you can see on the map, those towns that are in yellow are what you would think of as municipal health departments that have a full-time director. So most of them are sort of multi-service organizations, multi-staffed, multi-service, but for a single municipality. Those towns that you see in white are mostly smaller rural towns that have a part-time health director and possibly 1 or 2 sanitarians on staff. And all of that other area that you see in blue is where one or two or more towns have come together to offer public health services as a district. A district can be anywhere between 2 and 20 towns. So we had gone about 10 years ago to our members, who are all the health directors in the state, and we had asked them whether health equity was an important aspect of public health. They overwhelmingly responded that not only was health equity important, but that resources should be used to try to eliminate health inequities, and that they needed to engage other sectors and outside partners to do this. They did complain that they had a lack of local credible data, and that was a big problem for them in addressing health disparities. So at that point, the Health Equity Index was born, and that's the reason for its existence. The Health Equity Index is a web-based tool that allows users to examine how community conditions and demographics may correlate to health outcomes at a neighborhood level. We have 3 data sets in the index. We have the social determinant data set that's made up of 77 indicators that have been grouped into 7 domains. We have health outcome data that's made up of 33 health indicators in 13 health categories, and then demographics. All of the data that we have, in order to be included in the index, had to be available for every town, city, every municipality in the state. The index uses a decile scale, which has been set up to allow users to compare data across all towns and cities in the state. The state median is assigned a score of 5. A score of 1 would be a less desirable score, less health enhancing. A score of 10 is the most desirable. So this is what you would see if you logged in and you wanted to look at a particular town. And this just happens to be the town page for Hartford. You can see the 3 domains, or the 3 data sets. On the left, you have your social determinants, which are the 7 domains that I discussed, each with their decile score. And those scores are averaged to give an overall social determinant score. You have all of your health outcome categories, which are averaged together to give a health outcome score. And then you have demographics. You can also look at all of these, this data at a local level, and this is at a census block group level. So you have all of the same categories, the same domains, and the same demographics. Here you can see, so if one had clicked on the housing domain, you can actually see the indicators on the left, or some of the indicators that are in that particular domain. We also have correlations, and we do Spearman ranked correlation coefficients. These are not in any way meant to imply causality between a social determinant and a health outcome. They are strictly there to start looking at how things relate to one another and start conversations. We look at anything that's above a 0.3 level is starting to have a moderate or stronger level of correlation, so that you can see here that infectious disease has a fairly high level of correlation to low housing scores. The index also has GIS mapping, and you can do side-by-side visualization of individual social determinants and health outcomes. So here you're looking at housing scores and infectious disease, and you can start seeing patterns. These types of images have been really, in our pilot studies, have been really important in bringing these things to municipal leaders and to the community, in allowing some of these conversations to start. And if you actually click on any one of these census block groups on one of these maps, you go directly to that census block data set. Okay, so we started pilot testing the index a few years ago, starting first with 3 local health departments and then an additional 7. And we found really large differences in how efficiently they were able to use the index, to what extent they used it. A number of our sites use the index quite extensively for grant writing and workforce development and work in the community and strategic planning. And some of our sites actually never really used it at all. And so we wanted to know why. We wanted to know what made a local health department more or less likely to use this kind of a tool. And that was the start of this particular PBRN research project. As we were thinking about it, we tried to think of what we thought might come out of it, and we postulated that the demographics of the population served by a health department might play a very major role. That if you had a less economically secure, more racially and ethnically diverse urban population, that they might be more interested in using a health equity index tool than a rural, homogeneous, affluent community. We also, in looking at some of the pilot sites, thought that maybe leadership styles or ideology of the health director himself or herself might also play a big role in what sort of determined whether or not a health department was going to be a successful user of the index. So we started collecting data, and we started with two secondary data sets, or two sources. The first was that all Connecticut local health departments do an annual report to the State Department of Health. And you can see some of the things that they collect in that report, whether or not the director is full-time or part-time, how many hours they work, whether it's a department or a district, rural or urban, suburban, where they get their money, so that whether they get grants from the federal government, whether they go out looking for grants from the state or for private foundations, also whether or not they have a board of directors, and whether that board is either advisory or policy making. We also use data to look at the population served by the local health department. We used 2010 census data that we had populated on the index, along with some other index data. So we looked at population size and density, geography, diversity measures, measures of poverty. For poverty, we looked at the percentage of people in the particular municipality or district that were living in poverty. And we also used the overall education score from the Health Equity Index. And this gave us a data set of 15 variables for every health department in the state. There were things that we still didn't know, and we decided to do a survey of all of the health directors. We developed a survey, which we actually have available. If anybody wants to see it, they can contact me, and I can make the actual instrument available to everyone. The survey was administered using SurveyMonkey, and we sent out repeated notices to the health directors. We asked for their participation. We offered access to the index, and we also requested their assistance on the research project, thinking that maybe if they were not actually interested in the index itself, they still might be willing to help us out with our project. Only the health directors were given the survey and given access, or original access to it. And we put this in place, and only the ones that completed the survey were given access. And we did this because we wanted to entice more health directors to complete the survey. So the survey itself asked questions about the background of the health director, the makeup of the staff, their activities in the community. We specifically asked questions about whether they were going through the accreditation process, whether they were working on community needs assessments. We also asked questions aimed at determining the health director's views on health equity and social justice as a role of public health. So every health director who completed the survey was sent an access key that could be used to register for the index. If more than one person in the health department wanted to use the index, they could use the same key, but they were asked to register themselves, because we wanted to keep track of how many users were using the index from each health department. We also offered training because we knew that the 10 original pilot sites had already had training on the index, so we offered anyone who wanted it hands-on, on-site training, and 9 health departments asked for this training. And we tracked usage over a 7-month period. We used Google Analytics, and we looked at the number of logins, the number of page views, and the number of users in the local health department that were actually using the index. At the end of the primary collection period, at the end of the 7-month period, we sent out a final survey to just find out how a health department used the index and who in the local health department, in terms of what their actual position was, who was actually using the index data. So now we had 2 data sets. We had the data set for all local health departments, and that just included those 15 variables that we had of secondary data. We also had a second data set, which was for all of the health directors who had filled out the survey. So we had those 15 secondary data points and an additional 39 data points from the survey, for a total of 54 data points. For all of the health departments in the state, we asked the question, what characteristics of a local health department would make them more or less likely to choose to take part in a study on the Health Equity Index? We could not ask any more than that because we didn't have the primary data. We didn't have survey data from those health departments. For that data set, we used the non-parametric Wilcoxon-Whitney test to try to see which characteristics related to participation. We then looked at the data that we had on those health departments where we had survey data. The group had a smaller N. It was only 40 out of the 74 health departments, but a much larger group of variables. For this data set, we asked the question, what characteristics of a local health department could best predict index usage? And for the analysis, we used proportional logistic regression modeling. So these are the results that we obtained for the first data set of all of the local health departments in the state and whether or not they participated in the study. Full-time health directors were more likely to complete the survey than the part-timers. We found that if the population served was more racially or ethnically diverse or less economically stable, the health director was more likely to complete the survey. The same thing was found with the education level of the population, that health departments that served populations with lower education scores were more likely to participate in the survey. What we were surprised about was the strong correlation between the presence of a board of directors and survey completion. And this was true whether the board was advisory or policy making. There was no correlation between different funding sources and whether or not a health director participated in the study. There was no correlation between whether a health department served a rural or an urban community. So as I said, 40 of the 74, or 54% of health directors completed the survey. The percentage of full-timers was a lot higher. We then turned to the usage data, and we divided the users into 4 categories. The non-users were those who had registered and never logged in. The light users were what we thought of as curiosity users. They logged in 1 or more times in the first few days after receiving access, and then they disappeared. Moderate users really fell into 2 groups. Some used the index intensively for a number of weeks after first gaining access, but then we did not see them much after that. Others logged in sporadically throughout the project, using it for a few days at a time at each occurrence. And then we had our heavy users, or super users, and they used it consistently throughout the 7 months. They logged in often, they looked at multiple page views each time, and generally they had more than one user from the health department who was using the index. So our next task was to try to model this data, to figure out which variables, which of the 54 variables fit into our model of predicting usage of the Health Equity Index. And only 2 variables contributed to the model at all. So this was sort of surprising, is that everything fell away except for 2 things. Years a health director had been in his position was predictive of index use, and slightly less so was the number or percentage of MPH on staff at the health department. And here you can see the confidence intervals for that model. And if anybody wants to see the whole model, I can send that to you as well. In looking at the post-usage survey data, we found out that our heavy users were using the index for a variety of projects. Often they were doing grant writing, working on accreditation, doing strategic planning or performing community needs assessments. Moderate users used it for a specific purpose. So if they had a particular meeting with a municipal official, they would use the index, and then they would sort of put it away until somebody asked them to present something specific that they might have to look at it again. But they did not use it as a day-to-day go-to tool. And light users were curiosity users. They spent a bit of time browsing through the index about their jurisdiction, and I hate to say this, but they also spent probably more time looking at the town where they lived as well. Okay, the implications of this study and our findings of the study, I have in two categories, and the first has to do with whether or not our health directors decided to take part in this study. And we looked at what characteristics made them more likely to do so. Full-time departments in diverse areas were more likely to take part. This was not surprising. Part-time health directors often ran departments that were more likely focused on environmental mandated services and had less of other services. Directors from departments serving diverse areas and economically challenged areas were more likely to be interested in a project about this, and this was whether or not they actually effectively used the index afterwards, but at least it piqued their curiosity. The presence of the board of the directors is an interesting finding, and it's something that we're going to bring to our members next month at our membership meeting. We're going to ask them really what their thoughts are about this. We think that it's possible that the board of directors brings a broader vision to the role of local public health, and that might be a reason why we find that they're more likely to be interested in this kind of project. When we turn to the implications of the usage findings, health directors who have been in their position for a longer time may have a broader view of their responsibilities. It also could be due to newer health directors being a little bit more focused on those jobs that they are learning how to do. And so they might not have the time or resources to be able to go further at that point. We're not sure yet, and it's another thing that we want to bring to our health directors. We weren't surprised that a higher percentage of MPH on staff also added to the level of index usage, basically because they're probably more comfortable using this kind of data. Before I finish this part, I also want to talk about the limitations. We understand that there were some limitations to this study. The sample size is small. Out of a total of 74 health directors, we only had 40 whom took the survey, and so this is not enough to make any real sweeping generalizations. But we think that these results are interesting enough to continue the conversation. We thought about whether or not we should have opened up the survey to other health department leadership other than the director of health. The health director was the gatekeeper for this, and if the health directors themselves did not want to complete the survey, then we did not get any usage data on the health department because they weren't given access. And maybe we might think in future times about trying to involve more health department staff in this so that we can see whether or not that's true. And the last thing is that utilization of the index may be influenced by factors that we weren't able to look at in this study. Many of our health directors hold their positions at the whim of municipal officials. What role is the political ideology of those officials, and does that play a role? There are other data sources which they are not laid out in this way, but there are other ways that health directors can get data. It is possible that if they're very comfortable with getting their data in other ways, that they weren't as likely to use the index. So we really have to think about that as well. There are questions yet to be answered, but we are continuing to look into these things. At this point, I'd like to turn the presentation over to my colleague, Michael Knapp, because one of the other things that we got money for in this particular project was to make some improvements on the index, and he's just going to talk about this briefly.
So, stepping back from the study that you've looked at, simultaneously we set out to improve the index itself, so improve the interface to the software and various aspects of it that we had been hearing from local health departments that were using the index needed to get done. So they were a set of really, I think, badly needed improvements that were requested by our LHDs, our local health departments, and that's sort of the simultaneous track of this project this past year. And the first thing we did was we ran a set of formal user reviews, interviews, data collection, watched people in the LHDs using the index, and began to redesign the interface soup to nuts, top to bottom. And the reason, I mean, frankly, there's just so much data coming at our local health departments, and not all of them have epidemiologists on staff, and so on. And so the ability to communicate complex information as succinctly as possible, as clearly as possible, is paramount. And really the only way we're going to do that is through a series of feedback sessions. And this is, was really our second cut at trying to get an interface to data about health outcomes, social determinants of health, and demographic information. I think what's unique about this project in Connecticut is what I call hyperlocal. It's really about neighborhoods. It's about very specific, small geographic areas, and that was also driven very much by what local health departments were requesting. They didn't want to see statewide information. They didn't have any interest in townwide indicators. They really wanted it as hyperlocal, as small a geographic aerial unit as we could get. This first slide that I'm showing you is just getting into one health indicator in one town in Connecticut. What does it look like when you land there? So I've got Hartford shown on this page. I've got the indicator, the health outcome, births not receiving prenatal care in the first trimester. Hartford scores 2. The way this works is we convert rates to scores, partly to protect confidentiality, partly to communicate succinctly that a higher score is a more desirable outcome in the case of health outcomes, and in the case of social determinants, higher, quote unquote, better, but that's and to do that, we do decile ranking scores. There's a lot of talk about how to score. How should we, how do we score these measures? How best do we do it? But I think we've taken a good first cut at it. Down the bottom of the page, let me see if I got a pointer for you. Over here, if I can get it. No, yeah, right in here are our neighborhoods. And you can click into those neighborhoods and see basically the same sorts of data that are being presented. These data are presented at the neighborhood level as well. And on the right is the correlation. So what social determinants and which demographic characteristics are correlated with this particular health outcome. Now, as soon as we showed this to our cities, we heard back that, okay, I know that my scores are lower in Hartford than the rest of the state of Connecticut. Doesn't interest me. In the case of this particular image, you'll notice that other than North Meadows, which is in the upper right corner of this map, that's an area that has very little population. It's actually a landfill there, so it's a large area with a small population. Other than that area, all the scores are red, are low. And so under the PBRN, what we did was we reran the model. You click on this button, similar towns, and then you get instantly, you get a new model. And that model is comparing your town to other towns in what I call the municipal reference groups, other towns that are, or cities in this case, that are similar to yours. So we divided up Connecticut into 8 similar communities, and we rerun our scores, we rerun our correlations. And then Hartford, for example, is able to see more variation and see how they're doing against their peers, other towns in Connecticut that have relatively similar characteristics. If you click on the correlation tab, what happens? And so here we have, I just sort of picked one incidentally, the health outcome with ambulatory care sensitive hospitalizations. That's a health indicator that we developed off of some research at NYU. Its purpose is, at least in theory, to measure failures in the primary care system. In theory, these hospitalizations should not have occurred if our outpatient care was working well in these communities. And again, the neighborhoods, this is a different town, this is Bridgeport. The neighborhoods here are showing lower scores. Incidentally, it correlates with factory locations across the state, locations of large factories, and we see a 56% correlation. Again, we present these by neighborhood. Here I don't have neighborhood names like I did for Hartford, so I'm presenting by census tracts. In a lot of cases, we present by block groups, depends on the data, on these data. Then I rerun that model by clicking on that tab that says similar towns, and all of a sudden the correlation goes away. What we're saying here is that correlation between factory locations and this particular health outcome doesn't exist within our cities. We see that more in rural areas, for example. So in some of the other municipal reference groups, that correlation will get stronger. So here we rerun this model with this municipal reference group cutoff. A couple other quick things to show you that we did over the course of this year as part of the PBRN. Here I'm showing you skin cancer incidence rate in Hartford. For the first time, we are now stratifying by time. So where we had access to data over a long enough time interval, where the incidence was high enough, we were able to stratify by time, and we worked on how to present this back to the local health department. I think this is really important because as we get more and more neighborhood specific with our information, what's happening is we're often presenting findings that obviously are incidental, are due to chance. So we can cut over time and create time series, look, that communicates this fact very easily. If you see the numbers bouncing all over the place as a user of this tool, you can begin to conclude that probably due to chance. Whereas if you see a trend or a very consistent pattern, a trend of an increasing score over time or a decreasing score, you may want to investigate further, a little bit more stock in the hypotheses you can generate off these data. And in addition to stratifying by time, what else was new under this project is the ability to stratify by race and ethnicity, which, since this is about health equity, it was a crucial advance. Here I'm stratifying our skin cancer incidence rates in Hartford by neighborhood, by race and ethnicity, and presenting these data. And then we do similarly within the correlations themselves. So here, skin cancer incidence rate, higher scores, higher skin cancer incidence rate scores correlate positively with household income, but not particularly surprisingly, when you stratify by race, you see that correlation amongst whites. We're not seeing it in other populations we were able to stratify by. And then the other piece that we did, and I think this was the last of the body of work that we did on the index under this project, was to stratify these correlations by time as well. And here you happen to see that this correlation between skin cancer incidence and household income appears to be increasing over time, going up from 47% to 57% fairly steadily during our time intervals. In other cases, we do see it bouncing, again suggesting how much importance should I attribute to this particular finding. So that was our work under the PBRN in terms of improvements to the index itself. And Maura, I think you were going to present plans.
Right,
What's next?
so really our upcoming plans, we're presenting this work to the Connecticut local health directors at their next membership meeting. We want to get some sort of, we want to get their ideas on why we found what we found in the study. We're currently having a group of epidemiologists from around the state evaluating the interface, and they should be reporting back to us fairly soon. And hopefully that we are going to have a full rollout of the new index very soon, the new interface. So finally, I just want to thank a few people. I would like to thank my colleagues at CADH, Sharon Mirza and Charles Brown, who were instrumental in supporting this project. The project was originally the brainchild of Jennifer Curtanis, who was the head of the PBRN in Connecticut before she went on to other pastures. And I'd also, of course, like to thank the Robert Wood Johnson Foundation and the National PBRN Coordinating Center for all their support and also for the funding for this project. So thank you.
Thank you
Fantastic.
so much.
Thank you so much, Maura and Michael. We do have some time for questions, so let's open it up and see if there are questions or comments that folks would like to make. And feel free, if you'd rather use the chat box, you can use that option as well. I guess I'll throw a question out. One question I had was whether I mean, this is fascinating work, and what an amazing tool that's been developed here, and I think very interesting set of questions that you all have explored around who's using this tool and understanding that. Any thoughts about, in terms of thinking about your next steps, looking at how this tool might actually be influencing the actions that the local health departments might be undertaking? Clearly, you've identified use and the types of use, and a lot of use around community health assessment and strategic planning. That should, one would think, that should lead to actually program development, policy development, actually implementing actions to address equity issues. Any thoughts about exploring those kind of issues further downstream?
I think that's important to really look at in a systematic way. I can say that just from sort of what we've seen as our members have been using the index, those who have been using it to make some major change and to try to do something different. I know that one of our health departments, one of our original pilot sites, had done a major program to try to curb teen violence in their particular city. And this was done from index data that really showed them quite clearly the link between youth violence and a lack of employment opportunity. So programs have been started in the city to try to address this. And actually, the violence in the city has been going down. Whether or not this is the only reason, I can't say, but it's been one of the ways that has been, I think, effective. And I don't know, Michael, do you have anything that you want to say about that?
Well, I thought a lot about this from almost the start of this project, because as we get engrossed in trying to score indicators, present these data, it's really not the purpose. The purpose is, some of the stories that we've heard anecdotally that are so exciting and kind of make the wind blow around how are these data used in this neighborhood, in this town, by this health department or this organization, community organization, and to begin to be able to capture those stories and move this from a data presentation, data interface to a continuous improvement tool and a support tool for really what's a very different process for local public health around partnership development and the work they need to do to work on health equity. So it's been, it's definitely part of the vision. The reality of getting there is hard. It's not, I guess this project is so large in every direction that I feel like it's generations of work and not something we'll get done next year. And in seeing it that way, you start to realize, okay, this is what we've been able to do in the past decade, and this is the work we have next. So it really gets at, I think, what's really the meaning of the work.
Great points. Other questions from our PBRN audience?
It looks like we have a couple in the chat box.
Oh, great. Anna, you want to read those off? Or?
Sure. I think Lizette has said microphones are open, so if someone wants to jump in, that's fine too. I'll go ahead and read Susan. Susan Zahner asks, she says it's a great resource. Do you have plans to make the structure and framework available to other states? That's an interesting question. I think I know the answer. Go ahead.
Well, I think that we have looked at working with another state to develop this tool with them. It's always a funding issue. This is not. I guess I could have Michael address this as well, but I think that one of our goals early on was to think about, was this kind of tool transferable to other states? Michael, are you there?
Yeah, I'm right here. I was going to say that the purpose is I think is to roll it out to many states. The only limitation, as I see it, really is getting the health data in at the neighborhood level, which really means census block group, census tract level information in other states, getting access to that information and getting it loaded. The social determinant side as well, there's some data that's very hard to get nationwide. It's probably less of a limiting factor. But without, the hospitalization records, without the tumor registry records and so on, it can't be in another state. So that's, but very much like in part of the feedback for the PBRN, we were looking at how to do our municipal reference groups that I was showing you earlier. Originally we had a model that was specific to Connecticut, and one of the reviewers said, no, you've got to come up with an algorithm that can be nationwide. And I think more and more our work is designed to be applied nationwide. It's only limited by getting health data in there.
Elaine, is your microphone on? Can you speak?
Oh, yes. Hi, it's Elaine O'Keefe from Connecticut, and I always love seeing the latest developments with the Health Equity Index. It's been a work in progress for probably 7 years now, and it was funded initially by grants from Robert Wood Johnson and Kellogg, and as Maura and Michael know. But I just wanted to add one more example of the way it's been used for policy. I was part of a team in New Haven that we piloted the Health Equity Index a couple of years ago, and we used the data, I think, effectively. That was, one of the older versions of the index to create a policy brief on violence in the city, which is the issue they really wanted to focus on, and the policy recommendations were all for structural change in the city, and so it's just another example of how the data can be effective.
One of the big things that the data was really effective at in our pilot studies was in workforce development. And one of the things that we found in the pilot studies was that in general, people did not necessarily understand health inequities and social determinants and their relationship before seeing them with this kind of tool. And so when we actually surveyed them before and afterwards, all of a sudden, health department workers were comfortable not only in the knowledge of what was going on in their communities, but also comfortable in talking about some of these issues with members of the community. And, for a health department, I think that that's huge.
Yeah, good point.
Terrific. I see a question here from Nancy Winterbauer. Nancy, is your microphone working? All right, I'll jump in and ask for her. She says it's an awesome tool and study and wonders if you've thought of comparing Google Analytics with CHA and CHIPS.
Oh.
Comparing Google Analytics with CHA and CHIPS. I'm not quite sure I understand in what way she's asking that.
She's typing away. So hopefully she's going to clarify.
I mean, I know that the index has been used. Hartford did their community health assessment for their accreditation application was done really intensively using the index. But I'm not sure exactly what her question is, so she's typing.
Still typing. I know that the National Institute of Minority Health Disparities and the National Institute of Environmental Health Sciences are hosting with EPA a joint environmental justice meeting later this summer in July in North Carolina, and I think that this tool might be of particular interest to a lot of folks in that room. Nancy has clarified. She says the CHA and CHIPS should indicate the use of the index.
So I think maybe what she's saying is there to look at whether heavy users of the index were they more likely to actually include in their CHA and CHIPS again strategies to address health inequities.
Good question. Not everybody who did CHA and CHIPS actually used the index. As a matter of fact, one of the things that we asked in the survey was, were they now or have they recently done a community needs assessment? And that fell out of our model immediately. So we had people using it who weren't doing CHAs and CHIPS, and people who were doing CHAs and CHIPS that were and were not using the index. So I guess it really was not predictive in our hands. No, it is not. It is not mandatory in Connecticut. I see that question from Nancy. No, we don't have that mandate at all.
All right, we've got time for maybe one more question. Does anyone have a burning question out there? Hearing none, we will once again thank Moira and Michael. That was a terrific presentation, and I'm sure we'll be talking a lot more about this moving forward. So thanks again for joining us.
Thank you.
My pleasure.
Next up, we've been expanding the program in recent months, you've probably noticed, to also have some guest speakers from outside the PBRN grantee community. And this month we are very happy to welcome Jeremy Pina from the Center for Advancement of Health IT, who's going to talk to us about the Public Health Quality Improvement Exchange. Jamie, are you there?
Yes, I'm here. Can everyone hear me?
Absolutely. I think that we're just switching screens.
Thanks. There we go. Terrific. Well, yeah, thanks everyone for staying on the call to join me. My name is Jamie Pina. I'm a research scientist at the Center for the Advancement of Health IT at RTI International, and I'm also an adjunct faculty member at the Rollins School of Public Health in Atlanta. Today I'm going to speak with you about the Public Health Quality Improvement Exchange, which is a project that I direct and is funded by the Robert Wood Johnson Foundation. And the project has been going on for just over a year now from the start date where RTI picked it up to begin development of the online community and to sort of get the whole thing started. I'm really excited to talk about it because we've made a lot of progress in recent months, and I think that there are some really, if you're interested in quality improvement in public health, I think there's probably a lot of interest amongst the group to talk about what we've referred to as pH kicks. So I'll start just by mentioning what quality improvement is. Probably most of you are familiar with quality improvement in public health. Often these kinds of initiatives are executed by public health professionals. And one of the challenges that's been faced over time is that there's not always a clear way to share what is learned across agencies once a public health quality improvement initiative has been executed or completed. And another important note for the purposes of our discussion today is that these efforts are usually paid for by various funding sources, and sometimes that kind of creates a disparate mechanism of dissemination. So documenting quality improvement in public health, there's a couple of standard ways to do it. Often they're written as short narrative descriptions in reports. Storyboards are a common tool to use, which do a nice job of displaying that work. They're also typically posted on the website of the funding agency that funded the work, and that has several benefits, but a few drawbacks as well. So the storyboard mechanism, the traditional report for quality improvement in public health, is useful if you find the right quality or the right storyboard that's relevant to your research or practice goals, and you read the entire thing. You'll usually get a very good and clear, if maybe a little bit simplified picture of what happened in the initiative, and the findings are reported. But alone, these kinds of tools or this form of reporting isn't really optimal for the public health community. There isn't an easy way to search all of the different quality improvement initiatives that have occurred. You might not find the specific detail that you're looking for, and you might not ever find the right quality improvement initiative for your purposes. So as I heard we were discussing the Robert Wood Johnson Foundation previously. The Robert Wood Johnson Foundation supports a lot of quality improvement efforts in public health, and through their time supporting those efforts and helping to establish a culture of quality in public health, they've identified a problem that I'll refer to today as information slippage, which is basically a concept where the knowledge that's gained through public health, through the execution of quality improvement work in public health, doesn't persist and make it to the next generation of practitioners that are going to take part in QI work. So to help reduce this problem, RWJ came up with the idea of creating an online place to store quality improvement work where it's searchable and where quality improvement initiatives could be cataloged and saved so that any public health practitioner could see them and learn from them. They developed a prototype information exchange for this purpose, and when they were ready to sort of take it beyond a proof of concept to an actual online resource, that's when they released an RFP, and my organization responded and won the contract. So the vision for the Public Health Quality Improvement Exchange, or like I said, PH Kicks, are the following. To share quality improvement knowledge across public health practitioners, and to provide them with access to quality improvement experts by way of feedback and discussions that occur online. The goal really is to create an online community dedicated to quality improvement in public health, and to provide guidance as people develop their quality improvement initiatives, and also, finally, to help support accreditation by making sure that each public health agency has a fair shot at creating a strong quality improvement plan for themselves. So this is a screenshot of the website of the Public Health Quality Improvement Exchange, and I'm going to talk a little bit about some of the features that are available, and then I'm happy to answer any questions that anyone has. I'll start with a few site statistics. Since we went live just right at the end of November of last year, we've had 8,750 site visits, 4,825 unique visitors, and the average time on the site is about 6.5 minutes. Almost 50,000 page views, and the number I'm most excited about is 740 registered users, that's 740 individuals who have chosen to come to the site and create an account so that they can log in, make comments on other people's work, and take part in the community forums and some of the other activities that we have. Right now, there are 57 quality improvement initiatives published on PHKIX, and we have 22 that are in the queue sort of awaiting final revision, and then they'll be published as well. And we have a whole number of sort of in progress, so rather a whole number of other initiatives that we know are coming, and people who have decided that they want to submit, and they've begun the process of collecting their data to go through the process. So PHKIX provides faceted search for quality improvement initiatives. Facets are, if you look at the screen on the left-hand side, they're basically just categories of data that you can search through. It's almost like you can create a dynamic query by clicking on the different features on the site. This allows practitioners to narrow down the QI initiatives that they review to a small number so that they can find something easily without having to create a query in a more structured query language or something. This makes it really simple to just point and click and find the QI initiatives that are relevant to your practice. You can also browse through all of the QI initiatives that we have published online. You can just go to the browse page and scroll through them, and if something catches your eye, you can select it that way. We place a lot of emphasis on making it easy to find the QI initiatives that we think public health practitioners are interested in. Some of the top search terms that come through the site right now are immunizations, lean, Department of Health, vision and infant mortality, and a few others. So you can search for the QI initiatives by keyword or by creating the query using the faceted search mechanism. So to develop the data collection template that we use for PHKIX, and we put a lot of time and energy into aligning it with the existing work in QI. So we reviewed a lot of different quality improvement profiles that already existed, and we used several resources that are listed here. We scanned through about 400 quality improvement documents to see what kinds of information were relevant. I'm actually going to describe that process in a minute. To review and refine the data collection template for PHKIX, we worked with a number of different public health practitioners as well as experts from a number of different public health special interest groups and some friends from academia to help us as well. And we feel really confident that the data collection template includes the information that is most relevant to public health practitioners with regard to QI, and it has sort of sufficient flexibility to provide a high level of detail while still being highly searchable. One of the processes that we went through to create the data collection template was using a word frequency analysis to analyze about 400 documents of public health quality improvement work. And we're presenting this research project at an upcoming conference later this year. It's called MedInfo, and it's a biomedical informatics symposium that takes place internationally every 2 years. My background is as a public health practitioner and an informatician, so I'm real excited to go to that conference and share our work. Okay, so again, here is the front page of the website, and I'll go into a little more detail. Right from the home page, you can access search, browse, and submit from 3 simple icons, and we found that users have a really easy time coming to the site and understanding what they can do right from the beginning. We're about to do a little bit of revision to the home page, but so far people have had an easy time accessing its features, and we seem to get a really good response from practitioners who have made use of it. Here's what the first page of a public health quality improvement initiative looks like when we publish it on PHKIX. At the very top is the title of the submission, and we have a quick summary that kind of captures the gist of the initiative. It's an abstract. typically written, and all of this content, by the way, is written by the public health practitioner who submits the initiative. So we're very proud of the fact that it's user-generated content. There's also a citation right on the front page. That is automatically generated through some code that we wrote to create an AMA-style citation. So the idea here is, as researchers, if you're interested in citing any of the QI initiatives on PHKIX, you can copy the citation and paste it directly into your citation manager or just into a paper. It's a way to give sort of a permanent place for the initiative to be referenced online or in any bibliography. And then you can see underneath the citation, there's a number of different headings, and if you click on those headings, you get additional detail about the QI initiative. We have a feature on PHKIX where it's called Ask an Expert, and if you are a public health practitioner with a question about QI, you can submit a question, and then we have one of our expert panel members respond to the question with some thoughtful feedback and commentary. And then users are able to log in, read that response, and ask additional questions if they like. We also have a news and events page where we share things that are happening with the project or things that are happening in the world of public health quality improvement. And we're slowly growing to have a number of different partners from public health interest groups around the country where we share their news and they share ours as well. The community forum is a place where anybody who's a registered user of PHKIX can go and post a question and have a discussion with their colleagues and peers. This has been a really useful resource, I think, for a number of folks who are engaged in quality improvement in public health, and we get some really neat discussions happening here. Most recently, we had some folks ask about posting agency plans or quality improvement agency plans on the site, and through discussion with the community, we were able to determine that sharing QI agency plans is really desired, and we're going to start doing that later this year. We have a pretty heavy Twitter presence where we tweet rather from the conferences that we attend and share news and updates this way. I actually just sent a tweet out referencing this discussion that we're having now. So if anyone's on Twitter and you can follow this hashtag, you can see it. So I took a stab at identifying some reasons why folks from the PBRN might be interested in PHKIX. I think that coming to the site and kind of scanning what kind of activity is occurring there would give researchers in quality improvement a sense of trends that are occurring in quality improvement activity in public health. If you're curious about what kinds of projects have been executed, what number of submissions have used a specific method or tool, you can find all that just from the search page. If there's a sort of domain of practice that you're interested in learning about, you can go to PHKIX and find that out very easily as well. It might also be interesting to researchers to see how practitioners describe their own work. All of the submissions on PHKIX are written by public health practitioners. So getting a sense of their understanding of quality improvement and the level of depth and detail they're able to go into might give you insight into what the field still needs and where there are kind of overall gaps in the knowledge of the practice community. The comments and questions might lead to that as well. For every submission that's online, or I'm sorry, every quality improvement initiative that's online, members of the site are able to, I'm sorry, not members, users of the site are able to make comments and ask questions of the submitter. And there have been some really interesting dialogue surrounding that. And also, you know, insight into the quality improvement community and then getting a sense of what their activities are. And this also offers an opportunity for researchers who probably have a much deeper understanding of some of the background and theory behind quality improvement work. This is an opportunity for you to share your knowledge with the community and to start to build new relationships with the folks who really care about public health and quality improvement. So our slogan, I think, for PHKIX is quality improvement together, recognizing that the public health community is very collaborative and folks are always willing to share ideas And the natural progression of that is to take that sharing online and to inspire each other to continue to do good work in quality improvement. So that is just about the end of my 15-minute presentation. And I'm really happy to take any questions that anyone might have, and certainly invite everybody to come over to phkicks.org and register as a user and join in some of the discussions. Thanks very much.
Thank you, Jamie. That was really interesting and a terrific example of some targeted information gathering and targeted information usage. Really appreciate the presentation. Do we have any questions for Jamie? We've got time for maybe one or two. All right. Hearing none, I will thank Jamie once again, and we will make sure that the PH Kicks is out there in our newsletter. We've already put it in a couple times. We'll make sure to continue doing that and trying to drive as much traffic as we can your way. Thanks so much for joining us today.
Thanks. It was a pleasure. And I'm going to drop off the call. I have another meeting at 2:15.
Terrific.
Thanks
so
again.
much.
It was great to participate. Have a great day.
You too. All right. Moving on down our agenda, we want to quickly welcome our new PBRNs to the mix. We've got new PBRNs from Alabama, Pennsylvania, Arkansas, who of course has participated in PBRN related work for some time, with Glenn starting out over there a few years ago, but they're now officially official, and Illinois, so we want to welcome our 4 new PBRNs to the mix. We're excited to continue growing and continue learning from each other, so I think we have a lot of good things in store for all of us with the addition of these 4 PBRNs. I know that we have some funding opportunities that Glenn wanted to tee up for you all. Glenn, are you there?
I sure am. Thanks, Anna. Yeah, we just wanted to highlight a few funding opportunities that have been announced just in the last few days or last week or so, just to make sure they're on your radar. These will obviously be profiled in our monthly newsletter, but just as an early heads up, a couple of funding announcements that came out from CDC just this last week. One we sent out last week that's out of the preparedness office at CDC, funding opportunity that was actually created through the Disaster Relief and Recovery Act of 2013, that very controversial act that was passed, that was supposed to be passed with the 2012 conference or Congress, that then was delayed till after the new Congress came in and was passed back in January. In addition to all the relief funding, it was part of that package. There was actually some funding for Smartly, for some public health services and systems research to look at how best to deploy resources to respond and recover from the natural disaster of Hurricane Sandy. That call hit the street last week for research, again examining response and recovery issues around Hurricane Sandy in the affected regions along the northeast coast. It's got a tight fuse on it, so take a look at it. We did send it out through a special email last week, but obviously this will be of particular interest to some of our mid-Atlantic and northeastern located PBRNs. It's got a short fuse. I think the letter of intent is due today, actually, and the grant itself is due June 6th. And so take a careful look at that. We know several of our PBRNs have interest and have done some research in the preparedness arena. Another issue from CDC in the last couple of days actually relates to injury prevention research. We've been talking with the CDC's Injury Center quite a bit in the last few months about synergies with PBRN. The announcement went out for funding for injury control research centers. CDC funded injury control research centers, both comprehensive research centers as well as developmental research centers. And so take a look at that if you're a PBRN that has interest in injury prevention and control related research. An interesting call came out recently from the NIH National Institute for Nursing Research related to research looking at innovative measurement tools for community-engaged research efforts, actually developing measures of community engagement in research and using those measures to study the process of community-engaged research activities. Obviously, this is an area that's particularly relevant to the work of public health PBRNs, which are in and of themselves community engagement mechanisms. So take a look at that. That one follows the standard NIH submission deadlines. An announcement just came out yesterday from the CMS, the Centers for Medicare and Medicaid Services, announcing the second round of funding for the Healthcare Innovation Awards. We saw this first round last year. These are largely implementation funding grants to actually implement innovative approaches to healthcare and public health delivery that can improve service delivery, improve efficiency, reduce costs, and improve population health. In this announcement that came out just yesterday, there's a particular focus. There's 4 areas of focus, but one of those areas relates specifically to linking clinical care delivery to prevention and population health. So there's the connection to the work of public health PBRN. So we know a number of our networks have got interest in studying mechanisms, processes, approaches for integrating healthcare and public health delivery. This is a great ticket. It's not a research grant per se, it's an implementation grant, but that obviously needs to have strong evaluative and research components. And CMS is going to give out a total of $1 billion through this announcement. Take a look at it. It's also got a fairly short fuse. I think there's a letter of intent process, and then the applications are due later this summer. I think in July, if I remember correctly. But take a look at your newsletter. It'll be out next week for more information on these and other opportunities. Or shoot us an email. Thanks.
I've also put in the chat box, I've also put links to the CMS Innovation Awards information. I believe there's a webinar on that scheduled for, I think it's May 28th, but the details should be available on that website. Just above that, I have the roadmaps to health prize information on the RWJF. Sorry, Glenn, just want to make sure everybody saw that.
Oh, yes, thank you. I skipped over that one. That one's a funding opportunity. It's from the Robert Johnson Foundation through our colleagues at the at University of Wisconsin who do the county health rankings and the Roadmaps to Health prize that's associated with that. This is more a prize rather than a purely funding opportunity, but definitely take a look at that if you're interested. It's a great opportunity for funding and recognizing innovative approaches to community health health delivery and health improvement.
And Justine asks what the CBPR funding opportunity is. I think that's the NINR, wasn't it? That was the Nursing Research Institute.
Yeah. Yes. Thank you. Yeah, that's the NINR opportunity for again looking at innovative measurement approaches for measuring community engagement in research activities.
Terrific. So again, we'll be highlighting all of these again in the newsletter next week, but we wanted to go ahead and give you a heads up that these things were coming down the pike. I also want to quickly touch on a few other things coming down the pike. We've got the grantee meeting survey is out for those of you who attended the pre-Keeneland PBRN grantee meeting. We'll try to get one more reminder out about that this week. We've had a pretty good response, but we'd obviously like to have as many folks respond as possible so we can make sure that next year's event is even better than this year. We want a continuous quality improvement. That's what we're all about. I also wanted to let everyone know that the Public Health Foundation, this is not on this list yet, but the Public Health Foundation's Academic Health Learning Centers have 2 webinars coming up. One is tomorrow and one is next week. And my understanding from Kathleen Amos, I've just put the link to the information page there, from Kathleen Amos at PHF is that they're going to spend a lot of time talking about the benefits and barriers of participating in academic health departments and their learning community. And they're really interested in getting a variety of perspectives. So if you have a little time tomorrow or next week, Thursday, May 23rd, either of those dates to participate in one of those webinars, I know the folks at PHF and the Council on Linkages would really appreciate that. We have some other webinars coming up. We have an Academy Health webinar on current priorities for understanding the public health system. These are going to be federal agency speakers who are going to be talking about funding priorities. Obviously, this is a good opportunity to get your ear to the ground and start thinking about crafting some research projects that would fit within the priorities for multiple funding agencies. So that's one of Academy Health's webinars coming up the 29th. Then in June, we've got the Public Health PBRN monthly virtual meeting, a research in progress presentation by the Wisconsin PBRN. I know Susan was on here earlier. We also have the Academy Health annual research meeting just around the corner. That's at the end of next month with a PHSSR interest group meeting. And we have had selected the PBRN scholarship recipients. I don't have that list in front of me right now, but we'll be sure to mention them in the June meeting. And of course, the NACCHO annual sharing session is coming up in Dallas in July. I think Lizette had something she wanted to mention, so I will pass it off to her.
Thank you, Anna. Yes, I just wanted to talk briefly about the final reports and products that are needed for your grants, specifically for the RACE grant, which has ended for most of you. We have the final narrative report and final financial reports, and of course all the different products, and I think we've received those for most everybody whose grant is over for that. However, we do need a bibliography, and some of you have not turned in a bibliography. That's part of your reporting requirement at the end of a project, and it's a complete list of materials from your project that are available for the public. So anything like publications, books, chapters, journal articles, reports, or websites, any proceedings and materials from national, regional events such as conferences and workshops, and any presentations or testimony that are publicly available. And there are guidelines of how this bibliography should be prepared. I will be in contact with those of you who have not yet turned in a bibliography, and I will guide you through that whole process. As far as the Improve grant, we do have most of the final narrative, actually they're annual, not final, excuse me, they're annual narrative and financial reports, and some of you have also turned in products, so I appreciate that. We do have one change in reporting to streamline our communications with the foundation. We're going to have all reporting sent just to the PBRN National Coordinating Center first, and that way we can review them, make sure that everything is fine and they're not going to be sent back to you. And after approval, then you would send them to grant reports and copy us as well. So that's just a slight change in policy. And we'll probably need them 1 or 2 days before the due date. So I'll make sure to communicate all of these changes with everybody, but I did want to make you aware of that, our new efforts to streamline our communications. And of course, I have links to the different reporting guidelines. So if anyone has any questions about that, please email me, and I'll be happy to guide you through the process.
Thanks, Lizette. And I see we have a question from Kim Guerin, and it's one that's probably on the minds of several of you out there. She asked if there's any information on the RWJF CTSA RFP that was pulled, and should you anticipate a revised RFP in the coming months. That RFP is on hold for a while. I don't know how soon they'll, the wheels of federal government turn slowly sometimes, and I'm not entirely sure when we can expect to see that again, but I would, and I think Glenn would concur on this, I would encourage folks to have a look at that CMS opportunity, because one of the 4 target areas has to do with clinical and preventive health. So if you've already begun some conversations with your clinical PBRNs around that CTSA, that might be something that you want to look at together as well. Glenn, do you have anything to add to that?
No, that's right on target. We are in ongoing dialogue and working with NCATS, the NIH institution that runs the CTSA awards. But at this stage, I don't have an exact timeline or time frame in terms of when we might be able to get an opportunity to re-release. But we are, we're working with them actively, and yeah, this is just part of the joys of working with your federal government. So stay tuned. But as Anna said, there are definitely other opportunities for pursuing this kind of collaborative translational research in public health settings and working with CTSA. So I say in the meantime, take advantage of any of these other opportunities if you've been able to surface a good idea with your CTSA.
Do we have any other questions? I see we have almost 8 minutes. I thought we were going to run over, but we're doing fine on time. So do we have any other questions or concerns any folks have?
I would just reiterate again back to Lizette's comments. Lizette is very, very good at knowing what RWJS is looking for in these reporting requirements, whether it's your annual progress report, your final narrative report, your financial reports. And so I think the change in policy she mentioned, having those reports come to us a couple of days before they're due at the foundation, that's primarily designed so that Lizette can, if we can identify any issues that we know RWJ is going to find, if we can find them first and help you correct them, that helps you put your best foot forward with the foundation, and hopefully can avoid RWJ kicking it back and saying we need X or Y. So just something that we're introducing to help improve the process and hopefully help you navigate these foundation reporting requirements a little bit easier.
Any other questions or concerns or issues or self-promotion that anyone would like to take care of? Terrific. Well, it looks like everyone might get a found 7 minutes. So I suppose we will call that a meeting for this month. If anyone does have any questions or concerns that you didn't have a chance to bring up in this call, by all means, please shoot Lizette or me an email. Again, before we close the Adobe Connect interface, if you have any of those URLs that you want to pull from the chat box, I recommend you do it. We'll leave it up for just a couple minutes so that you can do that. And wish everyone a great rest of your week. Thanks so much.
Thank you.
Thank you.